Members of the Senate online. Anyway, good morning. My name is Ed Harbison. This is the second meeting of our Sickle Cell Anemia Study Committee. I have one member with me, Chairman Kirkpatrick. She is here. We're glad to have you with us again today and really appreciate your input and the unique perspectives you bring about an issue that you had thought that we could delve into and make a contribution. So we'll ask you to input that as we develop our study and the final conclusion so we can get all that in. All right, we'll go by the agenda. If we got someone online on Zoom, I'm sure as we go along, we'll get those persons, pardon me, to testify. The first person I have up here is that Puha Mishra. Did I mess it up badly? Okay, you come up and to the podium and let us know what's going on. And give us your title. Oh, we got everybody for this. Oh, you all together. Oh, this all I got. Grady this morning. Go right ahead. Lower that mic for it, please.
Lower, okay.
There you go.
Is that better?
Yes.
Okay. Good morning again. So glad to be here. My name is Pooja Mishra. I'm the Vice President of the Cancer Center as well as Sickle Cell Center at Grady Health System. And I'll have my team introduce themselves as well.
You've been requested, if you're so inclined to do so, to remove your mask while you're talking. Is that okay with you? Or do you have,
Yeah.
unless you got an issue going on that you don't know why you're talking?
No, I'm good.
All right. Yes, ma'am.
So I introduced myself. I'd like for the team to come introduce themselves as well before we launch into the presentation, if that's
Please
okay.
do.
Okay.
I'm Morgan McLemore. I'm the medical director of the Georgia Comprehensive Sickle Cell Center at Grady.
Morning.
Good morning. I'm Nikita Barrett. I am the clinical director for the Sickle Cell Center at Grady.
Right. Good morning.
Good morning.
All right.
All right, doctor.
Okay, we'll go ahead and get started. My clicker trying to, yeah, thank you so much. Technical difficulties. It's not advancing the slide. Thank
Okay.
you. So wanted to quickly talk through the overview of Grady Health System. Over 125 plus years, as you all know, Grady has been an invaluable asset. We've served stroke patients through our Marcus Stroke and Neuroscience Center. We've got our state-of-the-art Corral Cardiac Center. We've got the nationally accredited Burn Center. It's one of two in Georgia. I'm very proud to represent our Georgia Cancer Center for Excellence and Avon Breast Center, as well as the world's first 24-hour comprehensive sickle cell center. And here's where I want to thank the support from the state to get us started in the first comprehensive sickle cell center at Grady. We could not have done it without you. In addition to these wonderful service lines, we also have our busiest level 1 trauma center, our 911 ambulance service that serves Atlanta, South Fulton, as well as 16 rural Georgia counties. We have our country's largest infectious disease program, as well as Georgia's only poison control center. At Grady, we have over 400 clinical trials at any given time. We've got command center for all regional disasters, as well as a training center for Army Ranger medics and the Georgia National Guard. Through the centers that we have at Grady, we serve more than 715,000 patients at Grady. And we have several EMS calls that we respond to. A quarter of all Georgia physicians have received some training from Grady. We are the largest hospital in the state with more than 953 licensed beds, as well as 153,000 patients treated in our emergency department. In our health system, we have 6 neighborhood health center, and we are represented by more than 7,200 employees.
All right. Let me raise this a little bit. So really brief introduction to sickle cell disease. It's a classic autosomal recessive disorder. In other words, you need 2 copies of the sickle gene to have disease. It's when you have 2 copies of this gene, it causes your red blood cells to be rigid, inflexible, that can include blood vessels and also easily break apart. And this can result in significant morbidity and even early mortality. Early studies in the 90s suggested that, let's see, is this the, yeah, suggested that life expectancy for the more severe and common forms was a life expectancy in the 40s. And then some of the variants, people could live into the 60s. However, more recent studies have shown only a modest increase in survival in the past 25 to 26 years. Part of this is probably related to just lack of access to care. Some of the earlier data was derived from dedicated sickle cell clinics, and more recent data derived from surveillance would suggest that survival was maybe not improved or maybe declined. However, when you looked at dedicated clinics, it does look like outcomes are better. As far as Georgia goes, there are approximately 10,000 people with sickle cell disease in the state. This is data derived from our colleagues at Georgia State in conjunction with CDC. There are about 5,400 adults. And birth rate is about 1 in 290 African-American births and 1 in 30 to 40,000 Hispanic births in the state of Georgia.
Excuse me, would you repeat that number of 5,000? What is that in reference to? Is that the total number
Total number in the state,
in the state, 5,000?
5,400 adults.
Okay.
And there's an additional 5,000 pediatric
10,000
patients.
total.
Yeah, roughly
you.
10,000.
Okay.
And that's a fluid number, of course.
Okay.
People come and go and and the number has increased over the past 10 years substantially.
Why do you think that is, Don?
People move here.
Oh, I see.
This is the place to be.
So,
Atlanta attracts people. In addition, the birth rate has not declined. It has remained roughly the same, about 1 in 300 African-American births. It's remained the same.
Chairman
Yes.
Kirkpatrick.
Do you think part of that is any change in the point at which people are diagnosed? Is there more early diagnosis going on?
Yeah, so there is universal screening, newborn screening. So people are diagnosed when they have sickle cell disease, but and they are also told if they have trait. However, they're told that they have trait when they're born, and I think sometimes that just gets lost over the years, or the significance of it. I know there's a lot of effort through the foundation to educate people with traits, saying that you need to know this in case the future, but I think that does get lost a bit over time. So the Sickle Cell Clinic at Grady was established 37 years ago by Dr. Jim Ekman, shown here. He's still active, although he's retired. He Professor Emeritus and still involved in this. This was established 37 years ago with funding from the state, Department of Public Health, which at the time pretty much provided most of the funding, and now is approximately about 50% of our funding. And I really have to give Jim a lot of credit, is that he established this clinic when very few people made it to adulthood. The life expectancy was in the 20s, early 20s at this point in time. But he had the wherewithal to establish the clinic, and pretty much the structure that it is today continues from what he established. And there was a lot of things that he did that were probably 10 to 20, 30 years ahead of its time, everywhere from just the structure of the clinic to the use of advanced practice providers like physician assistants and nurse practitioners. Our clinic is, of course, oriented around the patient, but there's a lot of people that are involved. We have the acute care, which I'll talk about in a bit. We have a dedicated infusion center, the clinic, and of course, we also have we try to have most of our patients when they're admitted to the hospital to a dedicated unit. And I don't have enough time to go through all the people that are involved here. I could probably spend an hour, probably 2 hours, maybe 3 hours, all the people that assist us, from nurses to medical assistants to administration, other doctors that are all involved in even the janitorial staff and all the people that help us. We can't do it without them. As far as the clinic goes, we follow about 1,400 patients in the clinic. Once again, this number kind of fluctuates, but overall has increased over the past 7 years I've been here, from 1,200 to 1,400. We're the largest adult clinic in the United States. I think the next largest one we think is Hopkins with about 800 patients. So we're almost double the next largest. We have about 3,300 outpatient visits per year. We have a transition program where we work closely with our pediatricians to ensure, or try to ensure, that people transition well from pediatric care to adult care. Dedicated social worker, psychiatry liaison, clinical pharmacist, dietitian. We also have a nephrologist and a neurologist who comes to the clinic because sickle cell disease does affect the kidneys, and stroke is a significant cause of morbidity and mortality in our population. In addition, we have a dedicated infusion center for transfusions, automated red cell exchange, and some of the newer intravenous treatments.
Could you expand on it a little bit for us, Doctor, if you would, and sort of, is that having any kind of, you mentioned about there's been no appreciable decrease in the number since the 90s. So is that having an effect on it now, the outcomes, benefit for people in pain? I understand pain is a huge
Yes.
problem with
Yeah. Pain is a huge problem, and once again, could probably talk a couple of hours on this. I think it's a very complicated problem, and I think the short up answer is, I think we, to this date, don't truly understand how to manage it properly, although we do aggressively treat it. But we are just now beginning to understand some nuances that we didn't understand in the past. But I'll talk about the acute care where we are set up to take care of more immediate.
Okay, and the cure aspect of it.
Yes.
Okay.
Once again, that's another couple of hours talk as far as cures
I'll
go.
condense it.
Yeah. So right now, there are 3 options that are potentially curative. Hematopoietic stem cell transplant or bone marrow transplant. And then there are gene editing and gene therapy. The hematopoietic stem cell transplant is a little bit limited in that not everybody has a donor. And probably only about 15 to 20% would have a donor. There is some mortality associated with the process, and there's a 10 to 20% chance of long-term complications from the transplant.
Well, the cure is worse than the disease.
It may or may not be.
Could be.
We were part of a large cooperative study trying to look at this, but we didn't accrue enough people to get a good answer from it. The gene editing and gene therapy trials are promising. However, they both have been put on hold and are now restarting because of some also long-term complications from these. So they may not be, we're going to probably resume them, but there are some cautions to them.
Doctor, Chairman.
I was just gonna say that's not very different from a lot of chronic diseases where we can manage the symptoms, we can treat the problem, but
Yes,
we're a long way from a cure on a
Yes.
lot of different things.
Yes.
Alzheimer's, Parkinson's,
Yes.
diabetes, just, you can
although
go on.
I will say with sickle cell, you can sort of envision a cure, whereas some of those others, it's really hard to envision one. But we've got some time We're
Okay.
not there yet.
We've been joined by Senator Jackson as well.
Mhm.
I'd like to recognize her at this time, as well as Senator Randy Robertson, my colleague from Columbus, Georgia, who's joined us for the sickle cell meeting. Thank you for being in, Mr. Chairman. Thank you. You may go right ahead.
Okay. In addition to the clinic, we also have the acute, what we call the acute care, which is the first and possibly the only 24-hour dedicated sickle cell emergency room. I wish I could take credit for this, but Jim Ekman established this 37 years ago. So this is an emergency room for people with sickle cell only. And it is open 24 hours a day, 7 days a week. We average about 3,500 visits per year. And, you know, roughly 25% of the patients are patients we do not follow in clinic because it is a true emergency room. It's open to anybody with sickle cell disease. Prompt evaluation and treatment. When we see somebody, we usually have them in a bed, getting fluids, pain medications, antibiotics, or whatever they need within 30 minutes. We also keep people for up to 8 hours, unlike an emergency room, which tries to figure out what to do with someone in 2 to 3 hours. Because of this, we have a very low admission rate. Our admission rate over the past 7 years has hovered right around 17%. Published rates in emergency rooms for sickle cell range from 40 to 50%. And many community hospitals say that they admit about 80% of the patients who come to the hospital. When we look at our data, we appear to have a lower complication rates compared to other hospitals. And we think part of this is that we promptly treat people quickly. And also patients aren't afraid to come in. They're not afraid that they're going to be looked at askance going, I have sickle cell disease, and be thought of as, you know, drug seeking or something. So they're willing to come in early, quickly, before they get really sick.
What about payments? You run into those kind of patients, and I should know this, but do
Mhm.
insurance companies cover this, or?
Yeah, they do. Although it's because of the opioid crisis, it's been a little bit harder. We have to jump through a few more hoops as far as the pain medications on an outpatient. But we've not run into it not be covered, but it's just sometimes a bit more work.
Okay, thank you.
Yeah. We also have a specialized inpatient care. We have a designated unit where we like to have our patients admitted to, with nurses that are familiar with the patients and also nurses that have input with how they are managed. We frequently collaborate in communication with our hematology team, and we have either nurse practitioner or physician assistant who rounds on these patients and engages with the clinic. In addition, we have a weekly meeting with both inpatient, outpatient, pharmacy, administration, nursing, pharmacists, and such to discuss patients seen in the clinic, acute care, and in the hospital to try and coordinate care. In addition to routine clinic care, which is never routine, we're also participate in many clinical trials. This is just I think this is not complete, but just an example, several federal funded trials, one from the NIH, well, 2 from NIH, 1 from HRSA, PCORI. And then we also participate in several pharmaceutical sponsored trials. And then internal, we have several things that we're looking at, including one of the big ones is trying to coordinate care across the metro area. Given that we know our patients don't just get admitted at Grady, they get admitted at hospitals throughout the area, and we're trying to coordinate to make sure that everything is uniform through that. And so how can you help? Well, continued funding is
You stole my question, but go ahead. That's a great question.
yeah.
Senator Chairman could.
Yeah, so I don't have my notes with me from our last meeting, but we did hear some pretty comprehensive presentations at that meeting as well. And children's was one of the presenters, and it seems to me that you guys are doing a great job. However, what we've got is sickle cell patients all over the state of Georgia
Yes,
who can't or don't want to or not able to drive to Atlanta for their
Sure.
care.
all of
And
those.
I think
That's
one of
right.
the challenges for our committee is trying to figure out solutions for whether it's a hub and spoke model, whether it's through Department of Public Health, through the federally qualified health centers. Other than money, we've got to find a way to better communicate to the physicians around the state and to the people providing the care around the state about taking care of these patients and get some resources broader area of metro, because what you guys are doing is great, but to me, the next level of your mission would be to help us solve the problem of the underserved areas of the state.
Amen. Amen.
Yeah, and this
Great-
is-
Great observation.
This is a problem, not just, well, let me put it this way. There are many large metropolitan areas that even lack an adult clinic, period. This, providers for adult patients with sickle cell disease are sorely lacking. One of our pediatric colleagues recently moved to Phoenix, and she contacted me because she's caring for 100 adults now, because there is nobody in Phoenix to take care of them. And there are some major cities along the East Coast that lack a functional adult clinic. So this is, if I may say, I would tend to favor a hub and spoke model personally, just based upon my own
Okay,
experience.
and how would that work with the medium-sized cities?
Yeah, I would hope that if there was a way of providing transportation, and I'm speaking on my own beliefs, not necessarily everybody's. I've always thought if there was a way of having like a shuttle bus or something to be able to come up and see us maybe twice a year, and then the remainder of visits being done by telehealth. I think we've all gotten better, unfortunately, at telehealth.
Mhm.
Well, fortunately, there's some good that has come out of the pandemic. Very little, but telehealth is one of them.
But can you draw blood? Do that? I understand. that they
Yes.
need the blood.
Yeah, you can
do
usually
that?
have people go to a local hospital and get blood
You
and
can
have the
do your
results.
analysis.
Yeah,
Okay.
fax to you. Seeing us twice a year and then, visits in between done by telehealth, I think it's the best. We have tried till we were blue in the face to identify providers in various locations that would work with us, and we never seemed to, people are just uncomfortable taking care of people with sickle cell disease. And I'm not sure how to fix that, but I
Okay.
think if we could figure out a way of, a shuttle bus bringing people up to us twice a year, and then,
So let me get your mindset about that, because I know in Columbus, there is an active group of people, Miss Lois Williams as an example in Columbus,
Mhm.
Georgia, and I think there's some kind of van that come down from somewhere weekly or with the hematologist, is that the right word? And apparently they got some kind of agreement or arrangement to bring
Yeah.
some assistance, but apparently it's not enough to what she's explaining to me to take
Yeah.
care of all of the pain and the need that people show
Yeah.
up with. But
And-
now, how do you see that partnership working, or an expansion of it some kind of way, I guess?
yeah,
And I'm trying to paraphrase what she would say.
yeah, I would say that we could be the kind of the consultants, expert consultants to kind of make an overall plan for the patient. And then that can help fill in. I mean, I don't mean any disrespect to anybody, but we do sickle cell, all the time. And that's what we do. We're, I don't like to tout myself too much, but
Understand.
we're experts. We know the latest. We do this as opposed to somebody who only does this part-time. and
We
is-
believe you. We just need that to spread to Columbus and Macon and
yeah.
Augusta and other places like that.
If you can get them up to us, we'll see them.
Chairman,
Yeah, back to my original point.
Yeah.
I mean, we've got to have some kind of train the trainer model other than just sending people up to Atlanta.
Yes.
Because that's just
Mhm.
not
There you go.
always going to work.
Right.
And so if we could figure out how to utilize our existing framework of resources through the FQHCs and the public health centers, the county health centers, it just seems like that would be a place to start, because
Mhm.
it's not all deciding who needs a bone marrow transplant, right? A lot of
Right.
it is treating symptoms and
Yes.
prescribing hydroxyurea and
Yes,
raising awareness about, who needs to be shipped.
right, right.
Yes,
I don't know if
Dr.
there was a
Proceed.
question in there. So
Go ahead, Doctor.
No. No, this is, we have been, we have tried to identify people that would work with us.
Mhm.
And, we'll have somebody who lives in one of these outlying towns, and we're trying to manage them, knowing that it's hard for them to get back and forth. And, we'll spend a lot of time calling, trying to find somebody that would, help us manage this patient. People, there's a reluctance.
do you think that's because of the of lack of knowledge, or do you think it's the issue with the opioid problem?
I think
Because that certainly shines the spotlight on people's DEA number.
Yes, I think it's both. And then, let me make sure I phrase this properly. Most of the people who see sickle cell patients in the community are people who are trained in hematology, medical oncology. In the community, you are really primarily a medical oncologist, because that's where you make your money. And taking care of people with sickle cell takes a lot of time, and it takes you away from doing the things that make a lot of money, which is, treating people with cancer.
No, that resonated. I understand that that's not a lot of good money is coming in from that, but.
Yeah.
Well, it's just like, I think, and I'm sure that's been applied at Grady. Football is going to bring in most of the money, but you fund the other programs from basketball, track, and other programs.
Yes,
Would that be the way to do that? Right.
yes. Or change the reimbursement for sickle cell.
Yeah, good luck with that.
Easier said than done.
Yeah, absolutely. But we're looking at it. Trust me, I think.
That way you would have more
Good
people.
focus on it, I believe.
Yeah.
So,
Hate to sound cynical, but it would bring more people into it.
yeah. Anybody else with your program? Any other comments with presentation from Ms. Barrett?
No.
Okay. Are you about done, Doctor?
I'm done.
Well, we really appreciate it. Really interesting and informative and very good education and input. And I got this person and group that works very well in Columbus. And just as Chairman Kirkpatrick mentioned, they got their thing going, but they need resources, they need information, they need your wonderful expertise to come down and not bleed down to us, but come down to us and have a good positive impact. We really appreciate what you do.
Yeah.
Thank
Right.
you. If you don't get any more thanks from anybody else, this committee thanks you sincerely.
Thank you.
All right.
Thank you for
Appreciate it.
having us.
Yes,
Thank you.
we appreciate being able to come here. Thank
Any
you.
questions and comments? Thank you very much. At this time, Ms. Kim Smith Whitley, EVP and Head of Research Development, Global Blood.
Hello, good morning. Can you hear me?
Yes, we can. Thank you. Good morning.
Senator Harbison, I just can't thank you enough for your important work for the sickle cell community. The Sickle Cell Anemia Study Committee is obviously very well versed in the needs of those living with sickle cell disease. And I'm just honored to be able to be here today with you, Senator Jackson, Senator Robinson, and the rest of the Sickle Cell Anemia Study Committee to really talk about some of the health care disparities and social inequities facing individuals living with sickle cell disease. I want to start by giving you a little context. I actually am a pediatric hematologist. I've been the director of the sickle cell program at the Children's Hospital of Philadelphia, where I've been privileged to take care of 1,000 children living with sickle cell disease for about 30 years. In May, I transitioned from that role, even though I continue to see patients, to being head of research and development for Global Blood Therapeutics. I was attracted to Global Blood Therapeutics because since its inception, they've been dedicated to making a meaningful difference for those suffering from devastating blood disorders, starting with sickle cell disease. And we have a drug called Oxbryta that is focused on the root cause of sickle cell, the sickling that happens within the red cell due to something called polymerization of hemoglobin. And I know that you all are so aware of sickle cell disease. I don't need to tell you that that underlying mechanism leads to the early destruction of red cells. It leads to, unfortunately, anemia. It leads to the cells getting caught up in the blood vessels that lead to tissues. So it impedes oxygen delivery to tissues. So if you're impeding oxygen to a bone or a muscle, that leads to pain. If you're impeding oxygen flow to the brain, that leads to a stroke. And these are just some of the complications facing those with sickle cell disease. And I don't need to tell this committee that individuals with sickle cell disease, despite newborn screening, despite getting on life-saving penicillin in the first few months of life, which Georgia is famous for doing so well, individuals still die early, 30 years premature compared to their African-American counterparts. And to me, I just think that's unacceptable in this day and age. We talk about sickle cell disease being a chronic condition that's looking for a cure. We know that the cure for sickle cell hematopoietic stem cell transplant requires chemotherapy in really, really strong amounts, to the point that it can lead to long-term and short-term devastating complications. The other piece of that is when you have to use chemotherapy, you have to have a relatively healthy person, right? So you have with sickle cell disease the challenges of it being an inherited blood condition. So you have to have a brother or sister that's a perfect match for a bone marrow, as well as not having sickle cell. And then you have to be healthy enough to receive the chemotherapy in order to get the curative therapy. So what Global Blood has focused on is trying to find disease-modifying therapies to make individuals with sickle cell disease better. And hopefully we will find this to the extent that we can make sickle cell a manageable chronic illness. I was part of a council called the National Academies of Sciences, Engineering, and Medicine Strategic Plan for Sickle Cell that was commissioned by Admiral Jawar. And during that process, we just provided recommendations that came out in September of 2020. Through that process, we actually visited Grady because we knew that they had an innovative approach to addressing issues with sickle cell disease. We were trying to find places that could provide high quality care. And I'm glad that you have programs like Grady in your state. But you're exactly right. We have to make sure that that high quality care is available throughout the state. And one of the problems with that is not having centers of excellence that are accessible through that Project Echo model that I heard one of the committee members talk about, that hub and spoke mechanism. So we at GBT are really looking for our partners that understand that we really need to do something that are going to get disease modifying therapies into the hands of those living with sickle cell disease to make sure individuals have high quality care. So Oxbryta was FDA approved for the use in children 12 years of age and older and adults with sickle cell disease in November of 2019. That drug, right, is now one of only 4 medications for sickle cell. The first patient with sickle cell was described in 1910. We knew down to the genetic level the cause of the disease by the 50s, and we still don't have a universal cure, and we still only have 4 disease modifying therapies. So I challenge the committee. That is not equal. And the reason is because of the health disparities that the sickle cell community has faced and the social inequities. It is not unique that people of color are facing these issues. When you look at the stigma associated with sickle cell disease for being drug seeking, it's because the same medicines we used to treat pain in that patient in 1910 are the same medicines that we have today. And that is not equitable. When you have seen what has happened to hemophilia, cystic fibrosis, HIV, we know that we can do better for sickle cell disease. For Oxbryta in the state of Georgia, you have to prove that you failed hydroxyurea in order to get on this medication, when in fact, the studies of 274 patients that we showed benefited by increasing their hemoglobins on Oxbryta, 2/3 were on hydroxyurea. This drug is meant to be used with and without hydroxyurea. So it's unacceptable that physicians prescribe this medication and then are told that their patients can't get it because they have to fail hydroxyurea first. I really think that advocating for centers of excellence through a hub and spoke model is really the way forward. I believe that improving disease modifying therapies, making sure that individuals with sickle cell disease have access to them. 2/3 to 3/4 of individuals with sickle cell disease are not on disease modifying therapy. So the 4 that we have, we're not even using well. So I hope this committee really uses the resources that I hear in the room and the inspiration of your knowledge and your dedication towards the sickle cell community to start leveling the playing field. I think we can do it by improving surveillance through the CDC funding that you already have there in Georgia. It needs to be more. We need to find centers of excellence, support them through a hub and spoke model so there's access to universal, high quality, respectful, and compassionate care. Thank you so much for your attention, and I hope you have questions for me this morning.
Yes, members of the committee, questions?
No.
Yes, Senator Jackson.
And this may, thank you so much for your presentation and for your lifelong dedication to this issue. This may actually not be a question that you can answer, but who's making these decisions about what drug a person can receive and when? Who's making these decisions about the reimbursement for treating sickle cell children? Who has the power to make change in that?
You do.
Is it-
Yeah.
That's an oversimplification,
Can I
but
take
really,
a
it really
stab
is
at
true.
that?
Senator, yes.
So
Yes,
there's
ma'am.
2 different parts of it. The first part is what the state controls. And the second part is what the state doesn't control.
Right.
And so the part the state controls is through the Department of Community Health. And the part that the state doesn't control is through the insurance industry, some of which is regulated by the Department of Insurance, but a lot of which is not. So that's the answer. And we've been trying to work on this through, Senate Bill 80 that we passed last year for prior authorization and other efforts. And I don't think we're finished with that, but there's 2 distinct pathways where people may be getting their the reimbursement for their drugs.
Good, Donald. You done? Well, this Oxbryta, Chairman Kirkpatrick, can you give us an enlightenment from your perspective? You don't know anything about it. I don't either. Dr. McLemore, can you say something about it or give us your opinion and take on it? I think we've heard this before, but I'm not sure. Can you? And we know about the chemotherapy type stuff. Will you tell us about that, please?
Yeah, so-
your perspective.
Yeah, so Oxbryta has been recently approved.
It has been approved.
Yes, it has been approved. We do utilize it. And there are, lots of hoops to get through to, get patients on it. We still prefer hydroxyurea because it has a long track record, decreases hospital visits, decreases transfusions, and in some studies has shown to prolong survival.
What does it do in layman's term? What?
Hydroxyurea?
Yes, sir.
it does two things. First, it increases your body's production of fetal hemoglobin, which will, in other words, you have less sickle and some more kind of normal types of hemoglobin. And so it disrupts this sickling. It also has an anti-inflammatory property, which probably should not be, dismissed.
And that's compared to the Oxbry.
Yeah. Yeah. The Oxbryta,
Right.
just binds to the hemoglobin molecule and prevents it in the sickle form from forming these polymers. It does, about half of patients will have over a gram increase in their hemoglobin. So it will raise hemoglobins. So in other words, they'll become less anemic. Markers of what we call hemolysis will go down. At present, it has not been shown to reduce hospital visits. And of course, it's too new to show whether it has any impact on long-term survival.
Yeah,
thank you.
we are,
Yeah.
Senator Harbison, and thank you, Dr. McLemore.
Yes, go ahead.
We definitely are doing the studies to support demonstrating a decrease in pain. And we actually have 72-week data that shows that we're trending towards significant changes by decreasing pain the higher the hemoglobin goes. So we are definitely not suggesting individuals not receive hydroxyurea. We want individuals to receive hydroxyurea. If you talk to members of the sickle cell community, not everybody's excited about being on hydroxyurea. That's the beauty of what compassionate and respectful care, which they provide at Grady, is important to do, called shared decision-making, where you actually speak to the patient about the risk and the benefits of each medicine, and you make sure that they are in agreement for what they would like to receive. I think that the issue that I'm trying to emphasize today is that if Dr. McLemore, if Dr. Mishra want Oxbryta for their patients and they prescribe it, I want them to be able to get it for the patients that they think need it and not have to demonstrate that somebody has failed hydroxyurea before they can get that medication. I think that that's the important factor here.
Yeah, Chairman
Yeah,
Kirkpatrick.
so I just wanted to point out, and please correct me if I'm wrong, but I think you work for the company that makes Oxbryta.
I do, absolutely. I work for Global Blood Therapeutics.
Okay.
Yes. And what I'm advocating for as a committee is to make sure people have disease modifying therapies, which is why I think it's so important to do centers of excellence throughout the state. I think everybody deserves hydroxyurea. I think everybody deserves whatever medications the doctor thinks are important for them to receive. The fact that since 1983, there have been four drugs for sickle cell disease is what I think is a big disparity here. And so what I'm trying to advocate for all of those drugs, not just for Oxbryta, for all of those drugs to be available for individuals with sickle cell disease who need them, and not to have barriers to prescribing or access based on whether, if the doctor says that this is what they think that the patient needs, I think that the doctor should be able to get that for their patients.
Thank you, ma'am. Appreciate it, doctor. Thank you input. Thank you for your input. Our next speaker is Jeanette Newman Milford Green. Let me turn your podium on there. There we go. Good morning, afternoon. Well, good morning still.
Good morning. I'm Jeanette Newman. I am the Director of Operations for the Sickle Cell Foundation of Georgia. And I want to say thank
Can
you,
you pull
Senator.
your mic up just a little bit? Thank you. Yes, ma'am.
Thank you, Senator Harbison and the committee for this opportunity to speak with you this morning. So the Sickle Cell Foundation is a community-based organization, and we feel that community-based organizations have a very integral role to play in providing the best quality of life possible for people living with sickle cell disease. The mission of the Sickle Cell Foundation of Georgia is to engage, educate, and energize the community to improve the quality of life for people affected by sickle cell disease. And I can say I'm very pleased that we work very closely with Grady. We are in ongoing conversations in terms of what can we do, what more can we do to make it better for people living with sickle cell disease. So the purpose, so we look back, we started this project. The foundation has been in existence for 50 years. And for 50 years, we've been addressing the needs of individuals living with sickle cell disease. So we started by making sure that people were informed of their status. So we did testing, we had a mobile unit that did testing, we did testing in the schools. We were part of the group that advocated for the Comprehensive Sickle Cell Center at Grady and also for newborn screening. We've worked very closely with Dr. Ekman and others over the years to make these things happen for people living with sickle cell disease. As we looked across the landscape, I would say right around 2017, one of the things that we noticed was that there was limited access to care for too many people with sickle cell disease. So we set about crafting what we call the gold standard. And I have to thank all of you for your support, because the things that we're doing now are things that would not have been possible without the support that we receive from the state. So the purpose of the gold standard is to improve the health outcomes of individuals living with sickle cell disease, to reduce reliance on the utilization of emergency departments and urgent care centers, which as you know, are the most expensive forms of care and the least effective forms of care. Improve access to knowledgeable care and treatment of sickle cell disease with a focus on underserved areas of the state. So Senator Harbison, this sort of gets at your issue. You know, we have Grady, we're lucky to have Grady here in metropolitan Atlanta, but what do we have in Valdosta? You know, what do we have in Waycross? What do we have in Brunswick? So we really have to, so we set our sights on what can we do as an organization to reach out to those areas. In Georgia, okay. In Georgia, as has been indicated, we have about over 10,000 people. In fact, the most recent statistics as of January 2021, we have 14,777 people living in the state of Georgia with sickle cell disease. Of those people living in Georgia, 87% of them, 87% of the counties in Georgia are medically underserved. And 67% of individuals living with sickle cell disease in the state of Georgia reside in those areas, in areas that are medically underserved. We have 159 counties and we have people with sickle cell disease in 150 of those counties. If you notice on the map, and Dr. McLemore showed you the same map, if you notice on the map where the stars are, this is where people can access sickle cell disease. The two gold stars represent Atlanta and Augusta. Those are the only places in the entire state, and Georgia's a big state. I think we're the 15th largest in the country. Those are the only two places in the state where people can access care every day. Not necessarily 24 hours, but every day. Places that you see in red, those are places where they may be able to access care once a month. Individuals with sickle cell disease are thereby forced to drive long distances to get proper care. And many of them use emergency departments for their care. So access to care, to appropriate care, is a major need in the state of Georgia. 1.4 million Georgians are uninsured, and many more are at risk of losing their insurance. As you know, we have the fourth highest number of uninsured people in the country. No more than half of adults with sickle cell disease in the entire state have at least one sickle cell visit per year with a knowledgeable provider. So as Dr. McLemore has explained, and as it has been explained to this committee in previous years, sickle cell disease isn't just marked by pain crises, but the difficulties of the red blood cells creates organ damage. So over time, you know, the compromised oxygen flow is damaging the organs. And so even though sickle cell disease, it only affects a small population, it is a very expensive disease to treat. And it is a very devastating disease. And so it's important that people have access to regular routine care to keep down the cost of care, as well as to keep people healthy. Only 39% of Georgians have had a visit with a hematologist, and 21% of people in the state are uninsured and they primarily use emergency departments. So emergency departments are going to come up all the time. And these are not emergency departments like the sickle cell clinic at Grady. These are emergency departments with gunshot wounds and heart attacks. And so they're not getting the level of care that they need. So what we've done with funding that we received through the state is that we've established what we call the Access to Care program. And one of the things that we do is that we put community health workers in different parts of the state. And they sort of start as our introduction to that area. Community health workers are indigenous to the communities that they live in. They are lay community workers, they are lay health workers, and they serve as liaisons between individuals living with sickle cell disease and their families, medical providers, and other community resources. So currently we have CHWs in Atlanta, and in Atlanta we partner with Grady Healthcare Systems and Children's Healthcare of Atlanta. The Macon office, we partner with the Department of Health. The Augusta office, we partner with Lamar Medical Center. The Savannah office, we partner with Curtis Cooper. Columbus office, we partner with the Association for Sickle Cell Lower Chattahoochee, and we partner with Valley Healthcare. And on the slide, you can see the number of people that we've served in those areas since the inception of the project in 2017. So over the last few years, we've provided care coordination services to 1,523 individuals in 124 counties. 172 individuals are linked to medical homes or primary care for routine medical care. So it's important for individuals who are living with sickle cell disease to not only have access to a hematologist, they have to have access to a primary care provider or a medical home so that they're getting the regular screenings that they need to prevent complications that are associated with sickle cell disease. With organizations like Grady, all of that is assumed in one place. But when you step outside of Atlanta, you're dealing with having to see a hematologist and you're having to see a primary care provider. And so it's important that people understand that both of those are needed. We've linked 230 individuals to hematologists or a comprehensive sickle cell center for specialty care. And we've provided 435 individuals with supportive services. And that includes food assistance, housing assistance, and other practical needs. So care coordination is one part of the access to care. The other part of access to care is provider training. As has been stated, providers are reluctant to seek to treat people with sickle cell disease, non-hematologists. And so what we do is that we go across the state and we identify local partners and we negotiate training for non-specialty providers across the state. So they may not necessarily start treating, the training, it's a 4-hour training. We partner with Morehouse School of Medicine. They're not necessarily ready when they leave that 4-hour training to start treating people with sickle cell disease, but it changes their attitude. It changes their perception. And so we found that 80% have reported an increased comfort level in treating people with sickle cell disease. So, Senator Harbison, you were asking earlier, how do we, and Senator Fitzpatrick, how do we spread this out? How do we take Grady and spread it out through the state? So if we could get mechanisms in place where Grady sort of serves as in a consulting capacity, because that's one of the things that we hear from people when we go out and we do these trainings. What we hear from them is that they would feel more comfortable if there was somebody they could call, and do a consult with when they are presented with somebody who has sickle cell disease in real time. And we've tried lots of different things, to do this. The Office of Minority Health had a training program that lasted for a while. We have the ECHO trainings that we try to refer people to, but practicing physicians are busy.
Yeah.
And so we need something that's accessible to them and that's easy for them to jump into. So I think one of the things that we can do as a state is start thinking about what that looks like, and how do we create that kind of a structure. So to date, we have trained individuals in Augusta, Columbus, Macon, Swainsboro. We've trained pediatricians through the Georgia Academy of Pediatrics, and we've trained providers through the Georgia State Medical Association.
Yeah, but if I may ask one question.
Yes.
Regarding the Sickle Cell Association in Columbus, because I have knowledge of that one somewhat,
Mhm,
and the partnership, the community workers
mhm,
at Valley Healthcare.
mhm.
How does that work? What services does Valley Healthcare provide in conjunction with the sickle cell people in Columbus?
Okay, what we do with Valley Health is we're negotiating with them now. Prior to the pandemic, we were taking a hematologist into Valley Health so that we would see
Who pays for that?
the Sickle Cell Foundation pays for that with the funding that you have given us.
Okay,
So basically, DPH pays for it.
okay. Let me get this very clear now.
Mhm.
So there's a hematologist at Valley Healthcare in conjunction with treatment for sickle cell.
We take a hematologist into Columbus once a month.
I got you.
Yeah,
Okay.
and he sees patients at Valley Health.
At that
We were at
location.
Valley Health prior to the pandemic. And during the pandemic, as you can see on the next slide, we started taking the mobile unit down.
Okay.
And so we
Good
we
demo.
retrofitted the mobile unit as a clinic.
Okay.
Previously, the mobile unit was used for testing.
I've heard the clinic, yeah.
Yes, and
The
so
mobile unit.
now we're in the process of, we've done some work, we have some additional work that we need to do on that. So Dr. McLemore talked about, a shuttle that would bring people to Atlanta. Another way of thinking about it is maybe we could use the mobile unit to take Grady, to these underserved areas in the state.
And I'm not so sure that once a week is going to be adequate. You know what I'm saying? Somebody mentioned a daily opening. You said two places, I believe, Augusta and Atlanta. I mean, people are sick every day.
They are sick every day. The reality is we don't have enough hematologists in the state
Yeah.
to do this. And so, we're under-resourced when it comes to hematologists. And that's not just a problem in Atlanta. As Grady indicated, there are no incentives. There's a disincentive to see people with sickle cell disease. If you study hematology, you spend all that money in medical school and you study hematology, you can make a whole lot more money seeing cancer patients than you can seeing sickle cell patients. And that's just the reality.
Yeah.
And so what we have to do is really, we are under-resourced. And so what we really have to do is look at how do we manipulate the resources that we do have? How do we think outside of the box with the resources that we do have so that we can reach more people? We won't be able to see people all over the state every day, every week, but they will have, we can put systems in place where they have access, telemedicine. They have access to a knowledgeable provider, to an expert that can guide them and help them. And in their local communities, if the sickle cell expert can work with some of the providers in the local community who are willing to treat people who have sickle cell disease, then you have that medical knowledge, you have the primary care provider who's taking care of that person, and then you have he or she's linked to an expert to guide what needs to happen next.
Okay, let me acknowledge that leader, Senator Gloria Butler, has joined us by way of Zoom. We certainly appreciate having our leader on board. And at this time, Chairman Kirkpatrick has some comments.
Yeah, I've got several
Okay.
points I want to make. One is, it's hard for me to imagine any hematologist who's taking care of a significant number of Medicaid patients getting rich on that. That just is not,
Right.
that's not the case. So I don't want people to think that because I would guess that a lot of these patients are on Medicaid. I don't know that.
Or they don't have any insurance at all.
Okay. So then the role of the primary care doctors to me is super important because the specialists around the state, hematologists are not the only specialty that's in very short supply.
Yeah.
I mean, OBGYN, I mean, you name it. So I think we've got to find a way to get our primary care providers more engaged in the process
Mhm.
if we're going to be able to spread this throughout the state. And I'm wondering about the role of our medical schools. We keep increasing the number of medical schools and residency programs in Georgia. And it seems to me that upstream might be something we should be looking at in terms of ways to improve the education of primary care doctors around the state. And then the other thing I was going to mention is that we have a healthcare workforce board which is very active, and they do loan forgiveness and a number of other things. Sadly, their executive director, who's also the executive director of the medical board, passed away suddenly just 2 days ago at LaShawn Hughes. And so that's a terrible loss for the state of Georgia. But the workforce board would probably be a group to loop into this conversation because they probably would have some tools that could be applied. And then the only other thing I was going to say is that, we've addressed the opioid crisis we've got the PDMP now that physicians have to query before they prescribe a narcotic. But I think there's some tweaking that may need to be done because it's gotten physicians now to where they're very skittish about providing medications that probably are
Sure.
very necessary for a certain subset of the population.
Yes.
And in fact, our PDMP, I just read an article in, believe it or not, Wired magazines about this over the weekend, where prescriptions that are given for pets count towards the in the query that the physicians do. So if your pet has anxiety and they're getting benzos, those show up. They're not separated out. So there are probably some things we can do just from an operational standpoint to tweak that. But I really think the training has to start way before people are out in practice. And if we can find a way to focus on that, that might be beneficial.
Absolutely.
Thank you.
Sorry, there's not a question in there.
Thank you,
but-
Doctor. Senator Jackson.
I'm curious. So I have a dear friend whose son has hemophilia. And they have, it's a Black family, which is very rare for hemophilia, but they've received an extraordinary amount of resources through the Georgia Hemophilia Association or whatever. And so I'm just curious about, is there a relationship between the Sickle Cell Foundation and hemophilia? I mean, you have some similar needs, different population. And have we looked at them as a model perhaps, because they seem to have perfected being able to deliver care quite well in keeping kids out of the hospital, especially. And so I'm just wondering what we might learn from them. Have you all been in engagement with them as a potential partner in this work of trying to particularly care for kids with blood disorders?
I think there have been some efforts. I can't really say specifically. I think Dr. McLemore can comment on that.
Sorry.
Say your name again, Doctor.
Yeah, the hemophilia, first of all, the amount of funding they have is probably close to 100-fold per patient than in sickle cell. So second, and to their benefit, their therapeutics are more effective. It's a little bit of a simpler problem to fix. So, and, Dr. Watley Smith was, lamenting about the fact that there's been only 4 drugs despite us knowing the molecular defect since 1956 in sickle cell, but it's a little bit tougher problem to fix if you start thinking about, and I don't want to go into biochemistry because that'll clear the room out in a minute. But hemophilia is a simpler problem to take care of. We've been able to give just plasma alone for decades. And now they can, you're just replacing a protein and we can generate this protein in the lab. It's just a simpler problem to fix. But on the other hand, there are graphs and stuff showing that the amount of funding for hemophilia per patient is over 100-fold compared to sickle cell disease.
Is that dedicated funding from an agency or donated funding?
Donated funding and such like that. There's 120,000 people with sickle cell disease in the US and about 30 to 40,000 people with hemophilia, but the amount of money is it's astronomical.
These are white people.
Yeah. An example, our adult clinic with 1,400 patients, we have 2 full-time physicians and 2 part-time physicians. The hemophilia clinic Our adult hemophilia clinic has, I think, 6 or 7 physicians, and they follow about 200, 300 patients.
Thank you.
Enough said.
No, that's great input, but wow, that's something else.
Yeah.
Can you sort of wrap it up when we get a little short,
Yeah.
if you don't mind?
Yes, sure.
Yes.
So to date, we've seen 57 individuals using the mobile clinic. And we also provide support to community-based organizations, including the one in Columbus.
Right.
We've supported Tapestry, Sickle Cell Association of Savannah, the Heisman Sickle Cell Foundation of Augusta, and the Association of Sickle Cell. And so what we do is that we provide them with funding to assist people in their communities living with sickle cell. So moving forward, sustain the community health worker program in the state of Georgia to continue to expand.
Is that a paid position or a
It's
volunteer?
a paid position, and we want to expand to the southern part of the state. So if you think about community health workers, and I'll just give you an example. So one of the challenges, we've established that people need regular routine care to stay healthy, right? So Dr. McLemore, for example, he has a patient and the patient isn't coming for his follow-up appointments. So the CHW is the one that finds that patient, does patient education, make sure that that patient gets in for their regular appointments. If he knows on the front end that this patient has some challenges and they may not keep their appointments, that's a patient that the sickle cell, that the CHW can take on and really monitor that patient, make sure that that patient is getting to their appointments, making sure they understand their medical regimens, make sure that they're following them, as well as helping people that have other challenges. You know, they may need housing, they need the electricity bill. You know, it's hard to get somebody to pay attention to their care if the lights are off, or if they don't have gas, or if they don't have food. So those are some of the things that CHWs do, because clinicians cannot do it alone. You have to have the community side in order to keep people well, to get people well, and to keep them well. We want to expand the use of the mobile clinic to provide hematology services to underserved areas of the state. We want to videotape the non-specialty provider training so that it is accessible to physicians on demand. And as you indicated, Senator Harbison, what we want to do is get into these medical schools, get into these residency programs, and start training them before they actually start practicing. So part of what I think the state can do is help to negotiate those relationships. We need to leverage the resources to support and build the capacity of community organizations across the state. You know, we're one organization, but there are a lot of smaller organizations across the state that really need funding, and they really need capacity building so that they can better serve their communities. So we can fix this. I mean, we can do better. Access to what are some of the state level issues? Access to resources to pay for care. You know, some people just cannot pay for care. You know, Grady has a Grady card for people who don't have the funds to pay and they're not insured, but only Grady has a Grady card, and you have to live in certain counties to have a Grady card. Increase collaborations between clinical and community-based organizations, including data sharing to facilitate care and support. I want to go back to that example. So if Dr. McLemore is having a patient or a group of patients that he's having difficulty getting them to come in for their regular appointments, he can't share those data with us. You know, what we have to do is wait. I mean, we have these, you know, patchwork systems in place. You know, the patient may show up in the emergency room, you know, the social worker will make a call to the CHW and say, okay, Mr. Jones is here now. You know, if she runs up to the hospital to get informed consent from Mr. Jones, so then she can start providing support to Mr. Jones to make sure that he gets to his appointments. But what about the other 20 Mr. Jones that don't show up in the emergency room and their health is deteriorating? So a substantial portion of individuals with sickle cell are underemployed. Because of the nature of the disease. The nature of the disease is such that they miss a lot of work, but they may not qualify for federal benefits. So they're in kind of that gray area where they don't have the money to pay, they can't afford insurance, and there aren't a whole lot of programs out there. So we have to look at that. In the state, as I've said before, we have limited resources. We do need additional resources, but I do think we also need to think about How do we make the most efficient use of the resources that we have already? How do we rearrange things? How do we reconfigure things so that we can do more with what we do have? There is a need to a mechanism to facilitate collaboration, better collaboration between existing resources. And I think the state can play a role in that. Medical providers, as I said before, can't do it alone. There's a community side of it. And I think the state has a role to play in encouraging those relationships and making those relationships easier by removing the barriers. It's not profitable. We've said that. It's not profitable to treat people with sickle cell disease. And so we have to find ways to incentivize providers to treat people with sickle cell disease so that people have better access to care. So I thank you for
Thank
your
you.
attention and your opportunity and the opportunity to speak with you today.
Well, thank you for what you do every day. It's just tremendous, as is the other people who testified and commented and given us input. It's just really, really refreshing to know you got so many people trying to help, so few people trying to help so many situations in the state of Georgia, and likening resources and with the disparity in one, patient-driven situation as opposed to another. We need to look at that. And I've heard some great ideas from members of the panel as well as out here. We're going to have to get together and marinate that into some kind of help, some kind of way. Every little bit helps. And I think that we ought to pursue that. Senator Jackson.
Yeah, Senator Harbison, you may be able to answer this question as the Dean of the Senate, but I'm curious, we talked a lot about funding and funding disparities between other diseases. So do we know what the history of funding has been for sickle cell from the state of Georgia? Have we been consistently funding it around the same rates, or has that increased over time? Particularly, I think about the population of people who have sickle cell. It continues to increase because people like Georgia, which is great. So are we funding at a higher rate? Just, do you know that history?
I think there's been small increases, but I'll speak, I'll let her validate that. I'm pretty sure I'm right about that. But
Okay, so
and I want to know, but I think I know why the Centers for Daily Care is in Augusta and one is in Atlanta. So I think the Dean of the Senate knows that one because of that. But please go ahead and answer some of the questions.
So with the exception of hospital funding, community-based funding, we had a line item in the state for several years, and that was to do education. That funding was eliminated in 2009. And from 2009 until 2017, there was no funding for sickle cell disease. And so that funding was not reestablished until 2017. And
so it was cut out totally?
It was cut out totally. It was totally eliminated from the budget. And it was reinstated in the budget in 2017 at $150,000, which isn't a whole lot of money. And at that particular time, it was primarily to sustain a CHW program that we had started with seed money from HRSA. And we've slowly expanded that money to now it's about $750,000. But that's still not a lot of money when you think about a state as large as the state of Georgia. And, the needs of, we could do, we could do more with more. So, it's kind of a two-pronged approach. One is more resources. And then the other part is the state really helping us use the resources that we have more efficiently. So it's kind of really both of those things in order to kind of crack this nut.
Good. Chairman.
The only other thing I was thinking of is you mentioned other organizations that are working in the space. And Senator Harbison and I work a lot on veterans issues. And what I've seen in that area is that there are lots of silos in the nonprofit community, just like there are silos in state government. And so there'd probably be some benefit to trying to corral all the nonprofits that work in that area and get them on the same page, whether it's just meeting from time to time virtually or whatever. We've made some progress on that on the veteran side. So maybe that'd be something to think about.
We do work with the community-based organizations across the state. The challenge is most of those organizations are very small and they are volunteer organizations. That's one of the reasons, one of our asks is really for us to do capacity building. So minimally, they'll be able to provide services, in their communities. So, that's kind of part of what we're looking at. But we do talk and we do meet on a somehow semi-regular basis.
All right, thank you all. Thank you
you.
very much. I really appreciate that. Thank you so much for your valuable input, just tremendous learning curve for me. I think it's great. And prayerfully we'll get something done to help some people who are hurting. And they may not have the resources, but they have human needs. And we're human beings to help other human beings who can't help themselves. Sickle cell is, they say it is a horrific disease, pain-wise, and I wouldn't want to, have a relative suffering. I think I have. I'm thinking about it now. I believe I have, and I remember going to the hospital over and over again, and they passed early. So it's just a tragedy. But hopefully, we can avert and alleviate a bit with our input to this problem. But thank you again so much for coming. My staff here, Alex, he's the brain behind everything. Miss West right here, she makes everything come together. So we appreciate you. My colleague there, we appreciate you showing up, and we know you got the money in the budget to help us out. And we're going to be looking for that from Senator Randy Robinson from Columbus, Georgia, my colleague. You raised me right. Thank you. If there are no other questions or comments, we stand adjourned. I'm sorry. Senator Butler, are you still there? I believe
I'm
she.
still here, Mr. Chairman. Thank you.
Any comments, consideration?
No, but the presentation from Grady was great. I did, when the lady, I didn't know who she was a few minutes ago, mentioned $150,000 that was put back in the budget was an effort that I did. So, but I did not know that money had been taken out earlier in the years.
Not all the way altogether. I didn't either.
But thank you, Mr. Chairman, for recognizing me. I was there from the beginning. It just had a different phone number up there for me. I couldn't figure that out.
Well, thank you for your input. Appreciate you always, leader. Thank you.
Thank you.
Otherwise, we stand adjourned. Thank you very much. Appreciate it. Thank you.
I didn't know he was gonna call.